All right, guys, so today on Road to 250, I'm going to go over reading an ECG and a little bit of how to do the mean electrical access, AFib drug management, and then a little bit on Torsades. I'll just start off with, okay, so reading an ECG and mean electrical access. So I know this is pretty basic and only so much high yield on the USMLE, but I did think that going into a little bit of detail about mean electrical access points would help you in vignettes when they talk about that. So just to start off with the basics, in terms of reading an ECG, we want to generally look at take a couple steps as we read it. So first, we want to look at rate and rhythm. So is the rhythm steady, meaning how does it qualitatively look? We're looking for R waves that occur regularly, and if there's space between each R wave is consistent throughout the ECG. And so if it's not consistent, then we're looking at something irregular, and I'll show you guys that in a second in terms of a picture. And then the second thing is rate. So heart rate is the heart rate within normal range, which is going to be 60 to 100, not 200. Sorry, that's a typo. So here's a picture, and here we're looking at the peak, which is our R wave. And in this ECG, the rhythm and the quality of each R wave and the amount of time lapse between each R wave looks pretty regular and consistent. This shows pretty normal rhythm. And then the rate is going to be determined by, so I guess it's not really important to know the exact heart rate, but you want to see if they're within normal range. Like I said, between 60 and 100. And so you start at the R wave, and then you count beats down. So every 4 intervals is 75 beats. ECG shows you a guiding where it goes down from 300 to 150 to 100 to 75, which is where the next R point is seen. And so this patient's or this ECG would show that their heart rate is about, and that's normal, between 60 and 100. Okay, step 2 would be to look at the quality of the wave. So do you see a P wave, a QRS, and a T? Yeah, pretty much just looking to see if they look normal, and that would be step 2. And then step 3 is looking a little bit closer at the PR interval. So here you want to see whether it's in normal range. So you need to find the PR interval and determine its normal range, which is 120 to 200 milliseconds, or 3 to 5 boxes. So this picture is just representing your normal P, QRS, and T wave. So this is what our normal would look like. So if you see anything right off the bat that's abnormal, that means there is something happening in the heart. Okay, so sorry this picture is a little trippy, but looking at the PR interval here, this is what we want to look at closer, and looking at the grid lines, 3 to 5 small boxes starting at the P or 120 milliseconds as E point seconds. This is step 3, and step 3 is looking closer at the PR interval to see if it looks normal or abnormal. The normal would be indicated by either 3 to 5 boxes starting from the P to the R, or 120 to 200 milliseconds. So as we see here, starting at the P, we have 1, 2, 3, 4 and a quarter of a box, which is normal, as that falls between 3 to 5 smallest. And then I guess it would be important to see whether that seems consistent throughout the entire ECG, or at least through that specific lead that you're looking at. So that's that. Okay, guys, so step 4 is estimating the mean electrical axis. And this, or the mean electrical axis, indicates net direction of current flow during ventricular depolarization. So each lead can be represented by an angle, and that's indicated or represented in this picture here on the bottom right. And although the mean electrical axis isn't exact pinpoint precise, it is a way that we can simplify things, and even to simplify it a little more, we can use the quadrant method, and that will help us kind of figure out if our patient has something pathologically occurring. The normal range for the mean electrical axis is -30 to +110. And the horizontal lead is represented or indicated by the positive lead 1, which are, so I guess this is what's going to fall under the normal, is going to be the positive lead 1 at 0, and this is going to be in terms of reference or parallels to where the electrical node would be placed, would be on our left arm. And then the AVF here at the bottom would represent the vertical lead within this, and this parallel node would be placed on our foot. So moving forward, okay, so moving forward using the actual quad method, here in the top left, you see the quadrants and you see what they kind of indicate. So as I said, between -30 to 110 would be considered normal, but we can even simplify that and make that the 0-degree mark to 90-degree mark, or between lead 1 and the AVF lead. If we have a deflection or axis that gets represented between a positive lead and a negative AVF lead, then that's going to be considered left axis deviation, and so on and so forth. Because I'm going to actually explain that. So what we need to know, or essentially what we need to know before we can really use this quadrant method, is we need to determine if the QRS is net positive, net negative, or no net deflection. So the quadrant method is looking at the QRS in each lead, specifically leads AVF and lead 1. So on the ECG, you see all the leads. You're only going to look at, for the simplified method, AVF and lead 1. And when we do, we need to determine if the QRS is net positive, net negative, or no net deflection. So the deflection can be essentially, we can determine whether it's positive or negative by looking at how much is, I guess, the upward minus the downward in layman's terms. So looking at the first ECG tracing here on your left, the J point is going to be considered isoelectric, or the 0 point. And from there, you're going to determine how much of the deflection is above that and how much is below that. So in this first one, we're comparing how much is going up versus going down. So clearly we see that the peak is above almost about 2 boxes versus the bottom deflection is about 1. So I guess if we did the top minus the bottom, that would be 2 minus 1, so +1 positive. This is going to be a positive deflection. Looking at the second picture in the middle, could you guys tell me whether this would be a positive or a negative deflection?
Negative?
Exactly. It's a negative deflection because we're at -2, or I guess +1 plus -2. So it's -1 would be the equal out or down versus up. So yeah, it's a negative deflection. And how about this third box here on the right?
No net deflection.
Exactly. The amount positive is equivalent to the amount negative, so it's zeros out, so no net deflection. So this is how you determine when you're looking at your ECG in lead 1 and AVF, whether the QRS is positive deflection, negative deflection, or no net deflection. So then if we go back, the normal, or I guess here, this top right box, would show that the QRS would have, in lead 1, a positive deflection, meaning something looking like, oh gosh, this first box here. That's what you're going to determine. And then lead AVF is also going to be positive. So it's also going to resemble something like we saw in that first box. And together, this will indicate a positive and a positive, and so it falls between normal axis. So that's considered normal. Now, if we go down to the bottom left box, here we're seeing that in our ECG tracing, that lead 1 shows a positive deflection, so something like box. However, in the AVF lead, there's a negative deflection. So something like this is seen on the QRS in the lead AVF. And so therefore, it falls between 0 and negative 90 quadrant, and that would be considered a left axis deviation. And then last, the bottom right box, this ECG tracing is indicating right axis deviation. And when you are reading your ECG, lead 1 is going to show a negative deflection. Lead AVF would show a positive deflection. And so that results within the quadrant, and that would be a right axis deviation. So again, in words, when the net deflections for leads 1 and AVF are positive, then the mean electrical axis is between 0 and 90, which is normal. If the net deflection is positive in lead 1 but negative in AVF, then the mean electrical axis is between 0 and negative 90, and that is considered a left axis deviation. If the net deflection is negative in lead 1 and positive in AVF, then the mean electrical axis is between 90 and 180, and that means there is a right axis deviation. So now that you know what the ECG is trying to convey to us, we need to determine what does that mean for our patient. So if it's normal, then it's normal. If the patient's having some other symptoms, you got to look somewhere else. But if you do determine a left axis deviation, we need to think about the causes. The causes of this could be a left heart enlargement, which could be left ventricular hypertrophy or dilation. They could have conduction defects in the left ventricle, or they could have an acute MI on the right side, which tends to shift the axis left unless the right ventricle dilates. So if the acute MI is on the right side, it's going to tend to show a left axis deviation. The right axis deviation pathologies we can consider would be right heart enlargement, so right heart hypertrophy or dilation, conduction defects in the right ventricle or posterior left bundle branch, and then a acute MI on the left side, which tends to shift access to the right. Alrighty, so the next topic I'm going to talk about is long QT syndrome, also known as Torsades, something like that. And I guess the English translation of that actually is twisting of the points, hence why we see shifting of sinusoidal waveforms on ECG. So Torsades points is also known as polymorphic ventricular tachycardia, and it is all about the QRS, and that it is looking at QRS is going crazy, and there are excessive ventricular depolarizations occurring. So this syndrome is life-threatening, and its etiology consists of prolonged QT intervals, either through ventricular depolarizations and repolarizations that are resulting in QT prolongations. And this essentially increases the risk for tachycardia. So what causes this long QT syndrome? So as we see here, it can be caused by drugs, and we have a nice mnemonic or way to remember this. Long QTs occurs by antiarrhythmics, especially class 1A and class 3, antibiotics like our macrolides, antipsychotics like haloperidol, antidepressants like the TCAs, and antiemetics like ondansetron. In addition to that, torsades can be caused by electrical abnormalities with decreased potassium and decreased magnesium. And we can treat this by giving the patient, does anybody know? Well, it says it's here that you see. It's magnesium sulfate. So you can treat it by magnesium sulfate. I guess overall, torsades or long QT syndrome, you can treat by magnesium sulfate. And the last thing or cause for long QT syndrome is congenital abnormality. So in terms of the congenital abnormalities, it can be caused by genetics. So genetically, the potassium channel is mutated or abnormal incorporation into the membrane. And this can be broken down into two sub-syndromes, diseases, categories, Romano-Ward syndrome or Jervell and Lange-Nielsen syndrome, JBL, something like that, and Romano-Ward. Anyway, so the mode of inheritance for the Romano-Ward is autosomal dominant versus JLN is autosomal recessive. And the way we can differentiate these two syndromes is that the Romano-Ward has the potassium channel mutation only in cardiac cells versus the Jervell has cardiac and sensorineural deafness. So potentially some damage occurring in the sensorineural cells. So that is how you would differentiate the two. But essentially, the mutation in the potassium channels is causing the prolongation in QT interval. In addition to that, the Kaplan review books had mentioned sodium conductance here in this ventricular action potential seen here. And specifically when looking at this sodium conductance during phase 2, it's still slightly elevated here. It's not just like straight at 0 or I guess negative 70. And the idea is that potentially these channels, why it takes a while for it to reach completely at negative 70 is that they're slow to inactivate. And I guess data suggests that that could be affected by genetic alterations, and that can cause sodium current during phase 2. And that's going to delay the repolarization in the action potential, also resulting in a prolonged QT. So that can also play a role in terms of the congenital long QT syndrome. So I thought that was interesting. And I guess something to add on to what we need to know. Any questions or comments about this before I move on? Okay, so the last topic of the night I'm going to talk about is AFib management. So consider a patient, and this patient we're talking about is going to be a 63-year-old female, has history of hypertension, and comes into the emergency department with palpitations. So palpitations is pretty generic. but patient is found to have AFib and her heart rate is 125. So how do we manage this patient? If this patient has only had palpitations for a day, then we're going to do nothing. However, if the palpitations have been consistent for 2 days or more, we're going to consider this chronic, so greater than 48 hours, and we thus must anticoagulate the patient. The key steps that we want to take is first we want to rate control, so decrease the heart rate as it is at 125, and then we're going to anticoagulate. So in order to control the AV node or the heart rate, we can choose either calcium channel blockers, beta blockers, or digoxin. So looking at the calcium channel blockers, we are verapamil, diltiazem. And the adverse effects for these are going to be hypotension, constipation, peripheral edema, heart block. Could anybody tell me what the calcium channel blockers kind of work, or why we would get these types of adverse effects?
Because they control the rate.
Yeah, they control heart rate, but what are they causing? Like, why would we see peripheral edema and constipation? So the idea here is that we're vasodilating, and when we vasodilate, we increase hydrostatic pressure. So that's going to cause the peripheral edema. And then again, in the GI, there's smooth muscle vasodilation, so it's causing constipation. Does that make sense? Mm-hmm. Okay. The beta blockers, we're looking at the metoprolol. Propanolol is not very specific, like metoprolol, which is beta 1. And adverse effects, any other blockers is going to be hypotension, fatigue, depression, erectile dysfunction, and it does worsen dyslipidemia. Why would a patient on beta blockers have depression? So here the idea is like inhibition of catecholamines, norepinephrine, and dopamine. So if we are inhibiting norepinephrine and dopamine, then the patient is going to be sad or depressed, as in depression, norepinephrine and dopamine levels are low. And then digoxin. Digoxin adverse effects are dysarrhythmia, hyperkalemia, confusion, GI effects, most commonly dysarrhythmia. And hyperkalemia, what is the idea? What's the mechanism of action of digoxin?
Blocks that ATPase that has the potassium binding site on it.
Yes. Yep, sodium, potassium, ATPase, it's binding there and blocking it. So, yep. And then moving forward, cardioversion. So when to know whether to perform cardioversion on the patient with AFib, that may be, I guess, essentially. In order to need to resort to this type of management, the patient must be hemodynamically unstable. So that means the patient has chest pain, shortness of breath, hypotension, or confusion. And the way Conrad says it is that if they have shortness of breath, chest pain, hypotension, or confusion, that means they're not getting enough perfusion. So cardioversion would be the way to go for this type of patient. And then lastly, the long-term management after we've stabilized them is anticoagulation. This would be with warfarin, dabigatran, rivaroxaban, or apixaban. Warfarin downsides are that we have to, you have to check their levels, check their INR. And the therapeutic index takes about 5 days to get there. And warfarin is highly risky in terms of hemorrhage, so bleeding out. Dabigatran is just our factor 2 inhibitor, great drug. Rivaroxaban is our 10A inhibitor. And apixaban is a GP 2B38. No, it's not. It's a 10A inhibitor. So, yeah. That is drug of choices for anticoagulation. Any questions, comments, concerns, anything at all?
Can you go back one slide?
Yeah.
One more slide? Sorry.
Yeah.
So when you talk about Varenicline and diltiazem, you're considering those as the dihydropyridines or the non-dihydropyridines?
Dihydropyridines.
So the dihydropyridines would be nifedipine, nicarbamazepine, amlodipine, and all them.
Oh, okay, yeah.
So with Varenicline and diltiazem, I can see constipation, but peripheral edema might not be like a side effect for this side, for these two drugs.
Sure, okay.
So,
yeah, I would say I would agree to that. I guess in general, when talking about calcium channel blockers with dihydro and non-dihydropyridines, you can consider these adverse effects. I'm not saying that peripheral edema would be like the number one side effect for sure.
No, I know. Well, I just wanted to clarify that because I think in first aid that is a bit different because peripheral edema, if you think about it, as you said, it's a vascular smooth muscle, right?
Yeah.
So when you're
that would be
vasodilating,
I guess. Yeah.
So I would say that these two will probably affect the heart more so than they would affect the peripheral system. But you could see it still.
Yeah. Agreed. I see what you mean. Yep.
Yeah. Just clarifying that.
Mm-hmm. Yeah. No, that's right. Yeah, verapamil and diltiazem, like you said, they work more on the heart, so they're going to be more specific for like AV node control and atrial arrhythmias, like we're dealing with this patient with AFib. And then the adverse effects become a little bit more generalized to all like calcium channel blockers.
It's all due to the decrease in the contractility, so that causes the vasodilation. That's causing all the side effects.
Yes. Yep. Anything else? Okay, so I have a couple of questions. Yeah. Okay. So first question. A 58-year-old woman with idiopathic pulmonary hypertension presents with right ventricular hypertrophy and cor pulmonale. Her electrico or ECG shows a positive QRX complex and leads V1, 3, and AVF, and a equiphasic QRS complex and lead AVR. Which of the following is her mean QRS vector? Sorry, it's a little hard. So, okay, so keep in mind positive and positive deflection in lead 1 and AVF.
Is it D?
So using the quadrant method. No. Okay, sorry. I kind of just picked this question up because I found it. Okay, so we're saying C because, and here, so you guys can read it.
Because you have a positive lead 3.
Yeah.
Because it's
which,
V1.
I'm sorry, I didn't talk about that.
That's one.
Yeah, so, well, I can't. Okay, but yeah. So there is a positive deflection in lead and negative deflection wave towards. Okay, so biphasic just is saying like the isoelectric. So the equiphasic QRS complex and lead AVF indicates the mean QRS vector is 90 away from 150. If the QRS complex is positive and lead 3 and AVF of the mean electrical axis must move towards 120 and positive 190.
Yeah, since it's positive in lead 3, it's 120. If it was positive in lead 2, it would be positive 60. And AVR would be like 150.
Yeah. Yeah, that makes sense.
Could we see it on the diagram?
Yeah, if you wanted to, so the diagram saying the method won't completely work. Oh shoot, where are you?
I think it's
Only because
I just
quadrant
sent the
method.
picture in the chat if that helps you guys.
Yeah,
That's what
that
I
might be
use.
better because this quadrant method is only looking at lead 1 and ABF. And so if you just use this quadrant method, it might seem that's normal or between 0 and 90, but the 120 would be somewhere here.
because lead 3 is over there.
Yeah. Sorry, that was a mean question.
Oh no, it's fine. Learning point.
Yeah. Does that make somewhat better of a sense?
Kinda.
Okay. Next question. So here we have 6 lead frontal ECG performed as a part of an annual physical exam, and we're looking at what is the mean electrical axis of the patient. So here you should be to kind of use this version. So if we look at lead 1, we see pretty much a whatever you see there, and then ABF, and then that should help you kind of get a general idea, but to specifically, one sec. Oh, okay. Okay, yeah, we
Is
need
the
to look
answer
at lead
A?
3 a little bit closely. No. So, okay, so to start off with, does the patient have a normal axis or not? Based off of the simplified quadrant method. Right. So, yes, is right, because lead 1 shows positive deflection, and so does lead ABF. So that kind of takes out answer choice A, but then that still leaves us with B, C, and D because the normal axis is between 0 and 90. And I guess here, so the answer is T. Yeah. So it's saying that the mean approximate so the electrical axis is perpendicular to the axis of the limb lead with the smallest QRS wave magnitude. So in this case, the smallest deflection is in lead 3. And therefore, the mean electrical axis lies along ABR. And in ABR, the deflection is negative.
Yeah, that's what I was looking at.
So it's saying together.
Because ABR would be negative.
Right. And then, so I think it's saying together it's positive 30. Because the QRS complex is greater in leads 2 than 1, the electrical axis is between plus 60 and plus 30. Oh. Okay, well, these questions are a bit complicated. So, yeah, I guess you just have to, it requires knowing a little more, but it just seems that you can start off with using the simplified version of this question and then looking closely at, as it says, smallest deflection is in lead 3. And because, looking at, like Yash said, looking at that closely and seeing the peaks. So in lead 2, the QRS complex is greater than in lead 1. Probably by a little bit. They look a little bit taller than in lead 1. And so that's indicating an axis between plus 60 and plus 30. So plus 30 because the QRS is negative in the ABR, and then 60 because of the lead 2 is greater than in lead 1. So essentially, it seems that I would have had to go on through a little bit more details about all the leads, and I didn't do that. Sorry. Okay, next question. Last question. A 68-year-old male is admitted to the hospital for heart palpitations. EKG shows a irregular rhythm and absent P waves. The patient is started on warfarin for long-term anticoagulation to prevent atrial thrombus formation. Which of the following should be monitored in this patient?
B.
Yes.
Yeah, we'll go with that.
Yeah, the answer is B, because we're looking at extrinsic, which is PT time for warfarin, as it inhibits that extrinsic pathway. So that's all I got for you. Sorry, guys. Questions were hard. I thought I quickly last minute found some good questions. Didn't read them over very well.